Now moving on to the next lecture by Professor Dr. Hala Mahfouz, Professor of Cardiology at Menofia University. She's going to talk about imaging to detect hypertension complications.
Thank you, Mrs. and Mr. Chairman. Good afternoon, everyone. Inshallah, I'm going to solve this debate very soon and very clear. My talk is about imaging to detect hypertension complication. As all of us know that hypertension is the first modifiable risk factor that resulting in mortality not only in the United States but also all over the world. And the initial and the most important cause for this in patients having hypertension with systolic blood pressure 140 or more is the ischemic heart disease. In fact, we are not calling hypertension complication, but we now describe it as hypertension-mediated organ dysfunction or damage. This is what we mean by complication. In fact, this HMOD, when categorized according to the level or the stage of the blood pressure, both in the ESCC guidelines and in ACC guidelines, they placed that there is a very good correlation between the HMOD and the incident cardiovascular disease in both and two categories of guidelines. We will see that this is the incidence of cardiovascular disease according to the organ damage, both in ESCC and in ACC. Now, the long-standing hypertension or elevated blood pressure is associated with many effects on the whole cardiovascular and the non-cardiovascular organs inside the body. And this is started on the renal issue, the proteinuria and nephrosclerosis that may progressively lead to chronic kidney disease and end-stage renal disease, or in the cardiovascular system, especially the left ventricular hypertrophy due to the chronic pressure overload. It will result sooner or later into coronary heart disease, angina, systolic and diastolic dysfunction, and congestive heart failure. Also will lead to ventricular remodeling and the atrial remodeling that finally lead to ventricular and atrial arrhythmias, especially the atrial fibrillation, and also will affect the CNS parenchyma and the vasculature and lead to CNS transischemic attack, stroke, and eye complication. So the insult or the presence of hypertension or elevated blood pressure, especially if left untreated, will result in organ damage in a variable degree and according to the severity of hypertension. While the mechanism or the pathophysiology of hypertension to induce heart failure is through many pathways, especially the RAS system activation, apoptosis and fibrosis, but also there are combination or association of hypertension with other cardiovascular risk factors, especially hyperglycemia, diabetes, lipid abnormalities, and obesity. All will resulting or contribute to the development of heart failure. The hallmark in hypertension, in fact, is presence of chronic pressure overload, and this will increase the cardiac mass, resulting in arterial stiffness and increased arterial wall thickness, atrial myopathy, right ventricular involvement, and finally left ventricular hypertrophy with different phenotypes. I'm going to talk about it. And this will result into HFpEF, heart failure with preserved ejection fraction, and later on HFrEF, or heart failure with reduced ejection fraction. In fact, echocardiography is the most common diagnostic tool for detecting the etiology, the prognosis, and even direct the management strategy for patients with elevated blood pressure and those with hypertension, because in the new guidelines 2024, there are two terminology, non-elevated blood pressure, elevated blood pressure, and then hypertension. Now, in 2024 guidelines of the ACC, they placed the echocardiography as class 1 indication for every patient having hypertension, which means his blood pressure 140/90, as class 1 indication level of evidence B in all patients having hypertension with or without symptoms or suspicion of cardiac disease. And also they put patient with elevated blood pressure, which means below 140/90, as class 2B indication for echocardiography. In fact, this was also existing in 2018. Echocardiography was recommended in all hypertensive patients as class 1 indication. So we solved the issue. It's indicated. We have to have echocardiography, especially in the initial assessment of the patient having new onset hypertension. This is essential to recognize if the patient have end organ damage or not. Again, the echocardiography was placed on the top of the list for the optional test that used as a clinically indicated in initial workup of patients with elevated blood pressure or hypertension to assess the hypertension-mediated target organ damage. So its clinical utility is the detection of end organ damage, especially the cardiovascular system. Also, they put the coronary artery calcium scoring as one of the risk stratification for patients having at low or moderate risk, and those patients with hypertension should or probably will develop arterial stiffness and atherosclerotic changes, including plaque. Now we have to assess what's called LV remodeling in hypertension. What is LV remodeling? By definition, it is the change in size, geometry, shape, composition, and the function of the heart or that resulting from chronic pressure overload or chronic volume overload. In fact, this cardiac remodeling is one of the deleterious consequences of long-standing hypertension, especially if it is uncontrolled, and it is well correlated with the patient outcome. We need two parameters to judge the patient, the left ventricular hypertrophy and the remodeling. First, the relative wall thickness, which is derived from the formula 2 multiplied by the posterior wall thickness and divided by the left ventricular internal diameter. Normal value is between 0.32 and 0.42. This is the relative wall thickness. This is the normal value. And then the LV mass index. The LV mass index is normally below 95 gram per meter square for female and 115 for male. According to the two entities, the left ventricular, the relative wall thickness and the mass index, we categorize the geometry into normal relative wall thickness and normal mass, eccentric LVH with high or elevated mass, and the normal relative wall thickness, remodeling if there is increase in relative wall thickness and normal mass, and finally concentric LVH, which is the most critical and serious entity or phenotype where there is both elevated LV mass index and relative wall thickness. The presence of left ventricular hypertrophy, especially the concentric geometry pattern, is a strong and independent predictor of cardiovascular event and all-cause mortality. It increases the risk of sudden death by 3-fold. So the entity of concentric hypertrophy is the most serious one. The others are also important, but concentric hypertrophy with elevated mass and relative wall thickness is serious because it is usually associated with diastolic dysfunction and progress to diastolic heart failure or HFpEF. Also, it is associated with increased risk of morbidity and mortality, and that's why this phenotype of left ventricular hypertrophy and remodeling, we should consider it, and if it exists, we have to manage the patient carefully to avoid its progression into mortality. Long time ago, from the Framingham risk heart study, there is a relation between the increased left ventricular mass and the incidence of sudden cardiac death, both in men and in women. The increased left ventricular mass category or tertiles was associated with increased cardiovascular event and all-cause mortality. But fortunately, and the good news is the regression or reduction of left ventricular mass can be achieved with antihypertensive therapy, including the ARB and the ACE. This is on the top of the list, followed by the calcium channel blocker and the diuretic, and the least that caused regression for the LV mass is the beta blocker. Also, the use of antihypertensive therapy and the proper control of the blood pressure is associated with improvement in the vascular profile, improve the coronary reserve, reduce the attacks of ventricular arrhythmias, improve the autonomic nervous system function, and also improve the diastolic filling and systolic function. This is fortunately. Now the hypertension and the heart failure that we are looking for it. Long time ago, we've been describing the hypertension as disease of diastole, and it is considered to be the second cause for heart failure following coronary heart disease. The main issue in echocardiography is to assess the LV hypertrophy, I just mentioned, and the diastolic function or diastolic functional parameters. From the classification of heart failure, we know that there are 4 stages for heart failure. At risk, stage A, pre-heart failure, stage B, stage C, heart failure, and then advanced heart failure, or stage C. In fact, stage B of classification, it is described as patient without current or prior symptoms or sign of heart failure, but the patient has one or more of the following: structural heart disease, functional abnormalities, and or elevated natriuretic peptides. So I believe that imaging in this situation by all means is important to pick up the changes existing and to prevent the changes from stage B to the worst scenario, stage C and D. So imaging, whether using echo by all its different modalities or other technique, is important to make the patient stop at this stage and prevent progression to a more worse scenario. Again, according to the European Heart Journal 2021, the protocol in assessment of heart failure after clinical examination and the history taking and natriuretic peptide measurements, echocardiography is put as class 1 indication for assessment of patients suspected to have heart failure. And suspected means that the patient have dyspnea. So if he has dyspnea or shortness of breath and have elevated blood pressure, hypertension, this is one of the indications to have echo to prove or exclude presence of heart failure. Again, what's important is the use of ejection fraction. This very old and important parameter. It is used almost in all heart failure trials. The Paragon, the Paradigm, the TopCat, the CHARM trials, they all used this ejection fraction as a prognostic marker. And we're still relying on it to classify the patient with heart failure into half PEF, half REF, half mid-range or improved heart failure. But what's interesting is the use of 3-dimensional echo may be very beneficial to more accurately evaluate and assess the left ventricular function, and there are going research try to put this modality to measure and assess better the left ventricular function. Again, the diastolic function parameters, as we all know, there are more 4 important parameters we have to measure to assess diastolic function or heart failure: the LV mass index and the relative wall thickness, left atrial volume index more than 34 milliliter square body surface area, the E over E prime, and the pulmonary systolic pressure using tricuspid regurgitant velocity to prove or exclude presence of diastolic dysfunction and the heart failure, and this is the algorithm to use it to estimate the left ventricular filling pressure. In addition to the geometric parameters and the hemodynamic parameters from the mitral and tricuspid inflow, in addition to tissue Doppler examination, now we have the formational parameter which are essential to assess the systolic function, especially the subclinical systolic dysfunction patient with hypertension, including strain and strain rate imaging, whether longitudinal, circumferential, or radial strain. Again, Dr. Gamal was talking about this hypertension-mediated organ dysfunction. It changed the patient risk. It changed if it exists. So it will change the patient from low risk, even if his blood pressure between 130 and 140, to high risk, which means more focusing on the patient care and patient management, and even change the management strategy from non-pharmacologic to pharmacologic therapy. In fact, there is a very good relationship between the ventricular mass and the volume and the incidence of stroke, the incidence of heart failure, and the incidence of coronary artery disease. Now, myocardial mechanics using strain imaging become introduced to assess patients with hypertension, especially the category with in the stage of subclinical dysfunction or stage B. In fact, global longitudinal strain start to reduce even in the stage A, which means that patients just have hypertension as a risk factor. The global longitudinal strain start to decline, and then become more and more decline in stage B or subclinical dysfunction, and markedly reduced when the patient becomes symptomatic and there is overt heart failure. While the global circumferential and radial strain, in fact, only reduced when the patient become symptomatic with overt heart failure. This is one of the studies that proved that there is difference between patient having MACE, the global longitudinal strain and the LV mass index is elevated, while the GLS was reduced compared to patients who didn't develop a major adverse cardiovascular event. Also, the addition of global longitudinal strain to the clinical examination and the patient risk stratification will add value to the prediction of cardiovascular event and morbidity. Now the MRI, in very short, we know MRI, we use it initially for differential diagnosis of patient having left ventricular hypertrophy, especially if severe, due to hypertension or due to other entities for left ventricular hypertrophy like hypertrophic cardiomyopathy or atherate heart or amyloid or the presence of an atherate heart. All MRI technique is one of the mandatory and essential technique to differentiate hypertension, and also from a patient having aortic stenosis become easier to differentiate if the patient have LVH due to valvular disease or due to hypertension. Also the amyloid in conjunction with the ECG, strain pattern, and echocardiography. In fact, the CMR can be used in some situation when there is equivocal results from the echocardiography to assess the left ventricular function, mass, and the ejection fraction. Is very helpful. Also, like Dr. Azza said, we may use the CMR in patient having secondary hypertension, like in patient with renal artery stenosis, or patient with single kidney, patient having polycystic kidney, also patient having bilateral adrenal pheochromocytoma, patient with coarctation of the aorta. This is one of the importance of application of CMR in hypertensive patient. But again, we can use it for evaluation of aortic dissection or a huge aneurysm, like in this example of ascending aorta. Again, the CMR can be used also, especially with late gadolinium enhancement, to differentiate or discriminate the presence of myocardial infarction, which is also capable to differentiate the small localized area of infarction versus a large area of inferior wall myocardial infarction. Also differentiate the non-transmural versus transmural myocardial infarction with a very simple method. There is an inverse relation between the transmurality of the area of infarction and the recovery or the regaining of motion in patient-developed myocardial infarction. And finally, the CT angio. Again, the coronary artery calcium scoring is needed as a class 2B for patient risk stratification. But we also may use it for detection of obstructive coronary disease if the patient have any contraindication or didn't like to have coronary angio. And finally, this is one of the last researches which is very interesting to use CT angio by detection of inflammation of the periarterial fat. If it exists around any of the coronary artery, this is associated with increased risk for all-cause mortality and cardiac mortality. And so let me conclude that timely and targeted cardiovascular imaging is crucial in hypertension-mediated organ damage or dysfunction detection and risk stratification in hypertensive patients. While echocardiography is the first choice in assessment of cardiac remodeling in heart failure diagnosis, CMR is very helpful in patient having or suspected to have myocardial infarction and also to study the aortic pathology. Integration of the imaging finding enhance individualized management and guides the effective therapy, preventing irreversible organ damage in hypertensive heart disease. And thank you.
Thank you very much, Professor Hala, for this very informative talk. But for the sake of time, we will move to the next speaker.